another section of our lecture for August 31st, terrorism, mass casualty, and disaster nursing. And this kind of goes in conjunction with the emergency nursing and continuation, although this section actually spreads for the entire hospital, and to be able to be trained in a hospital or urgent care or clinic setting so that you understand what to expect. So our learning objectives for this section are listed here, and you can go ahead and follow through as we move along in the program here. Regulatory agencies and preparedness. So the regulatory agencies and federal agencies that are involved in bioterrorism, terrorism, mass casualty, and disaster are all regulated through the government and state and local systems. So bioterrorism, the reality of mass casualties and disaster are not anything new, but because of politics and because of world conflicts, we tend to still have, we're having a higher and higher population of terroristic activity, and weapons of mass destruction are part of that equation. So this is why we need agencies to help form task forces that help us deal with these kind of situations if they came up on a local level in our communities or in our facilities in general. So we have to have a hospital emergency preparedness plan. So it starts at the federal level, state level. They have an incident command control system, and then the hospital emergency preparedness plan. And that's the one that pertains the most to you as a healthcare worker and being a nurse if you are going to be working in the emergency room or even throughout the hospital, because the entire hospital system is involved in these kind of plans. So part of the terrorism, mass casualty, and disaster preparedness in hospitals, we have to have an emergency operations plan. Healthcare facilities are required by the Joint Commission to create a plan for preparedness for this type of disaster or mass casualty situation. Essential components of the plan have to include an activation response, an internal and external communication plan. There also has to have you have to have a plan. The hospital has to have a plan of coordinated patient care for dealing with these kind of situations, security plans, identification of external resources, a plan for people, and management of the traffic flow of where patients are going to go, how to triage, and that kind of thing. And we're going to get into all of that as we go forward. On page 2194 of your textbook, it goes into the different agencies that we discussed on the last slide on who is involved in the disaster preparedness planning and on the state and government and hospital level. Emergency Operations Plan number 2, the essential components of the plan are listed here. Data management strategy. I'm going to go into detail about the data that is involved in data management, is like the charting, the documentation, the schematics of the plan of taking care of the disaster. So everybody has to know each of their roles, the demobilization response, after action report or corrective plan. So after the event happens, we have to know how to get things back to normal and go back to where we were, how to deal with people who have been traumatized from the disaster, and kind of do a decompression situation where we get back on track. A plan for practice drills. I don't know about any of you, but I've been involved in many of the disaster drill or mass casualty drills that we've done, and they do them citywide sometimes, where the hospital has to have a practice run where they have groups of people who are at a high school, for example, participate as volunteers to be victims of a mass casualty or disaster, whether it involves terrorism, weapons of mass destruction, bombing, that kind of thing. And then the whole city has a plan on how many, like, which ERs will take how many patients. Northwest Hospital will have to take 10 of those patients. If it was like 100 patients, then TMC would have to take so many, UMC would have to take so many, and they have to practice this at least once a year to have a plan for something like that happening, because the city as a community has to come together to be able to handle something like that happening. And if we're not prepared, then that's when deaths can happen, unwanted deaths, or unplanned situations where injuries don't get the help that they need. We need to anticipate the resources needed for situations like that. We have to have a backup call list of nurses that you can call in an emergency. You have to be on, if you work in the emergency room, you'll have be on a list of whether you're working or not, you're coming in to help. And that's just part of being part of that organization. Mass casualty incident planning. That's the thing that I was just talking about, where they have practice drills on how many people are involved in the injury. We can have a little kind of a mock play of how that goes down, and planning how we would deal with situations like that. And education for all staff on all of this stuff. So they have to understand, all the staff, nursing, PCTs, everybody's involved. Radiology, the entire hospital is involved, and facility-wide. So everybody needs to be trained on this so that they know what's going on. So in the emergency nursing lecture, we talked about triage, but triaging in the mass casualty, terrorism, and disaster situation can be much different than what we do in the hospital. The sorting of patients to determine priority healthcare needs and proper site of treatment has to happen rapidly in a situation where you have hundreds of bodies laying out there, or tens of hundreds of people laying out on the field. We have to quickly triage. If you're breathing and you're not breathing, you're dead, you're not dead, that kind of thing. I know it sounds very cold and calculated, but it's not. It has to be done that way, because when you have a mass amount of people that are injured, you really have to sort them very carefully. It kind of goes back to the days of war, or in a war situation, where Florence Nightingale was one of the pioneers on developing a triage system of sorting patients that were just too far gone. If we didn't have the resources to fix them right then and there or get them somewhere, they had to be left behind. If their airway, breathing, circulation are intact, and they just have a mass injury that they can get fixed if we get them to care, that's a different situation. We'll get into that. In non-disastrous situations, healthcare workers assign the highest priority and allocate the most resources to the most critically ill patients. That is what we do in the emergency room. In a disaster situation with large numbers of casualties, decisions are made based on the likelihood that they're going to survive. Like I was saying, if you're in a situation where there's hundreds of people laying out there, you have to decide who can survive the situation more than another person. The North Atlantic Treaty Organization NATO triage system is considered red, yellow, green, and black. See that table in 73-1 in your textbook, and it'll go over all the different categories that we use. So again, red would be immediate. Yellow is the delayed. They can delay immediate intervention for a little while. Minimal is injuries that, such as a scratch or a cut, and they really haven't gotten any internal organ injuries. They're alert oriented. There's nothing going on. Now black is the sad one. That is the one where you have to decide that they're beyond help and resources at this point, and you just have to leave them behind. Triage considerations in a disaster involve managing internal problems. So the Emergency Operations Plan Committee has to determine what resources are needed or allocated for such events. In a disaster situation or mass casualty situation, terroristic situation, communication with family members that are outside the area and want to know what's going on, the communication with the media is really important because they can convey information to families that may not be able to contact the hospital or the area to get involved. So the facility communicating with the media as far as what's going on and what can be done to help families that are worried is really important. So we need to be sensitive to that. Although the media is really important in conveying information about what's going on in the city, we also have to tone it down as far as their ability to get private patient information and exposing the situation to get worse. Communicating the wrong information can be bad, a situation for a mass casualty situation, because it can actually worsen or cause the threat to be worse again. We need to care for the families of the victims. Again, goes back to the communication. And then stress management for both the staff and for patients and families. We need to keep our heads on. Frequently as healthcare workers, we're called upon to do that. But we also need stress management as well. When we're going into 13, 14 hours of caring for patients, sometimes in situations like this, that can be very stressful. So we have to also take care of ourselves. Since nurses are a part of the largest population of healthcare workers globally, we are in a position where we might be called upon in a disaster situation, a terrorist mass casualty situation, to perform the duties in our expertise. For example, if a critical care nurse is on site, they may be able to assist with putting chest tubes in or intubating patients. Other nurses might be able to do wound care and help patients in their specialty. So it's very important to understand what your role is. It's usually up to a good leadership system and having a plan in place where care is delegated to specific areas of patient needs. They may be asked to perform duties outside their expertise. Again, intubate, insert chest tubes. Again, they serve as a triage officer, triaging the patients, marking them red, yellow, green. Nurses have to maximize the patient living. They need to, their safety, this is supposed to say safety, not sagety. Beware of state regulation for a disaster plan. So that's all part of your disaster awareness training. And you'll get more extensive training if you work in the emergency room or in a hospital about disaster and mass casualty situations. So this is just an overview of those things. So don't panic too much about having to know every single element of this. Often in a traumatic situation with the disaster or mass casualty or terrorist situation where you're having to triage patients, the complex for nursing can be some of the things like assisted suicide. What I think they're talking about is when you're doing the yellow, red marking, we always want to save people, and it can be very complicated and very tough decision to be that person. If you ever found yourself in that situation, realize that you don't have the ability to detach yourself, then maybe getting another person to do that role might be a better way to go about it. Maintaining confidentiality, because you just want to be able to tell everybody, oh, hey, do you know this patient? Does anybody know this patient? We have to keep confidentiality abroad when we're doing stressful situations like this. Obtaining consent for care, duty, futile therapy, or situations where you know the patient's probably not going to make it through the therapy. There's a tough moral dilemma there that happens. How do we ration care? How do we resuscitate this one or not that one? becomes really tough. Even though most people in a traumatic disaster or mass casualty episode will come together, kind of like in 9/11 when the firefighters and the police officers and everybody was coming together to help people. Even citizens off the street were trying to help get people out and help in that mass casualty. It tends to cause long-lasting effects of the incident: anxiety, depression, impaired performance, PTSD, post-traumatic stress disorder, somatization. Usually somatization is where you really didn't realize how much the event is affecting you. In your brain, you're saying, oh, I got through it, I'm fine. But all of a sudden, symptoms of fatigue, malaise, headaches, GI symptoms, rashes, anxiety again, coming out in specific situations that is not cohesive with what's going on. So those kind of things can start to be a problem in these situations. Another big one is substance abuse amongst healthcare workers that are involved, or even people that are involved in the trauma. It can traumatize them to want to medicate themselves this way. Another part of mass casualty or terrorism or disasters is what kind of equipment should we protect ourselves with? We have our standard PPE that we use for infectious diseases, but what about when there's just traumas and blood everywhere and building particles and chemicals that were involved in the explosion and that kind of thing? The purpose is to shield the body, the healthcare provider, from the chemical, physical, biological hazards that may exist when caring for patients that are victims of this. They categorize it into different equipment levels. A is the self-contained breathing apparatus. This what they called underwater, but this is SCBA, so it's a vapor-tight, chemical-resistant suit. It depends on the situation, obviously, when they would use this kind of equipment. High-level respiratory protection, again, but lesser skin and eye protection might, if there's a leak of gas or exposure to gas instead of an actual chemical that's poured on anybody, that can be that situation. Level C is the air-purified respirator. That's usually the one you see where there's two filters on the side here. A coverall with splash hood for chemical resistant gloves, booties, that kind of thing, boots. Level D is typical work uniform. That's just what you wear to work, and that's the only thing. That would be the least protective, but depending on the situation and where you're working for that disaster, that's where you would go. Physical injuries after a blast event. And blast events can be explosions of any kind where there's a homemade bomb, for instance, a chemical reaction bomb, where the chemicals react and then they explode out. There's bombs that can include shards of metal that are intentionally put in to penetrate the skin. So blast lung is a primary injury that occurs where there's a shard or potential piece of metal that opened up the lung and is causing air to leak out. It essentially tears at the lung and can cause hemorrhaging and, of course, the inability of a person to breathe. A secondary can be a trauma to the inner ear, membrane rupture from the sound and the pressure that occurs from the explosion. Abdominal and head injuries are parts of that are shown on table 73.3. It gives you like a breakdown of each of these injuries, and it'll help you understand the different aspects of these injuries from a blast explosion. So next we're going to talk about the isolation precautions for biological terrorism agents. We've kind of gone over that a little bit with the protective equipment that we need to wear depending on what we're exposed to as healthcare agent facility and the patients. Biological agents may be delivered or spread in a number of ways because of off modern travel spread of infection may occur in areas of thousands of miles apart. And we're kind of seeing that, although we have not shown that the pandemic was caused by that, but it's an example of how quickly, if someone wanted to use a virus as a weapon, that could happen as a biological terrorism agent. And that can be something that an enemy would use to spread very quickly across many areas of the world. Healthcare providers need to be aware of the potential signs of a biological weapon dissemination. So it's similar to what happened with the pandemic, where tons of cases of this weird illness were starting to show up very quickly around a congested amount of time, especially in New York. But imagine that was something that was a biological agent, and you probably heard it on the news before in other countries. And you have to contain it very quickly. Isolation practices depend on the infecting agent, so it's crucial that emergency physicians, lab technicians, all get involved with what's going on, what has caused this weird illness to spread. Always use the standard precautions that you would, and then of course, especially if it's unknown and you see the similar symptoms coming out, definitely all the protective equipment, almost like what we're doing now with COVID. We have to wear all the stuff because we don't know who's infected, who's not. How does this virus behave? What do we do to avoid transmission of the agent to other people? Terminal disinfecting and disposing of waste. Again, I have to go back to how we're dealing with COVID-19, even though that's not a terrorist thing. It's definitely similar to how we would have to deal with it if we found out that it was used as a weapon. Common biological weapons are like anthrax. Anthrax had it came back up in the Bush administration, where someone was mailing anthrax in a powder form to government agencies, and people were opening envelopes where they're inhaling anthrax. The incubation time is 1 to 6 days. Skin contact, GI ingestion, inhalation, skin lesions, fever, nausea, vomiting, diarrhea, respiratory symptoms that mimic the flu are usually part of the anthrax. Thanks God we got on top of the anthrax problem when it happened. Treatment is usually penicillin and erythromycin or erythrocin. We're going to go ahead and pause at this point to go to our part 2, and I will see you in a moment.